So I'll be talking with you all today about molecular testing platforms, particularly the three testing platforms that are commercially available currently in the United States. And these are evolving, as is our understanding of how to use them together with all our other tools in managing patients who have indeterminate FNA cytology. I don't have any financial disclosures. Thinking about this, I should comment that I am much more familiar for various reasons with the Thyrosiq platform, Affymetrix, and most familiar with the CBL path UPMC platform, Thyrosiq, and a little bit less familiar and have less firsthand experience with the third platform from Interpace that's called ThyGeNext plus Thyromere. And I've done unfunded research assessing and reporting on our findings at a single center at University of Miami with both the Affymetrix and the Thyrosiq tests. So I actually have polling in my talk. This will keep you all awake. So we can launch the poll if you'd like. The question here is, which molecular tests do you use in your practice? And I know we also have an international audience too, and maybe you use different tests or you don't use a test. I should probably have included an option here saying none of the above, I use a different test. In some places, in-house testing is done, usually next generation sequencing. I'm assuming the poll has been launched. It's always helpful to get some information at the start about where the audience is at.
Looks like we have results.
Hey, are you able to share them? I don't think I am. I think if you click on share poll results, it should share it with the audience. Or...
I don't think so.
It's that you're sharing your screen.
Oh, so I would have to launch the poll. Do you want to tell us what you got? Maybe you can.
Yeah, we'll tell you. So we have Affymetrix GSC, 14%, Thyrosiq genomic classifier, 29%, the next gen Thyromere at 6%. I use more than one test is 10%, and I don't use molecular testing is at 41%.
Okay, great. Well, for those who don't use molecular testing, maybe we can get them to start using it. All right, it's always helpful to start with a case study. Now, I do have quite a few slides, so I'll go through some quicker and some slower. There we go, we can see the poll here.
Oh.
All righty, great, I'll close that out. Thanks for sharing. So this is a 55-year-old woman who went to a weight loss clinic, and for unclear reasons, she had an ultrasound. Probably the reason is that they have an ultrasound and an ultrasound tech that they're paying for. The clinical history is really unremarkable. So no symptoms, no risk factors for thyroid cancer, and she's not really all that overweight anyway. The TSH level is stone cold normal, and the ultrasound report states that there's a 1.8 centimeter hypoechoic solid nodule in the left lobe of the thyroid, which has microcalcifications and increased vascularity. We don't have the images, just the report, and sonographic risk stratification systems were not reported as often as the case, but I think those of you who are familiar with them would know that this would be an ATA sonographic risk high suspicion nodule or a TIRADS5, again, high suspicion nodule. And as often is the case, the patient has waited 3 months to see the endocrinologist, and she's so excited because this thyroid nodule is why she can't lose weight. So I'm going to help her. She's not so worried about the nodule, but she's worried about her weight, which is fairly average by today's standards. And I think I've learned from Dr. Tuttle and others over the years that a little bit of humor goes a long way in medicine. So I put in a little caricature here, and I don't know how it is where you all live, but at one of our major grocery stores, every time I go to the checkout counter, I see a magazine like that one shown here on the bottom right. Oftentimes my countryman, Dr. Mehmet Oz, is on it, or Oprah or someone, and they're talking about thyroid weight loss solutions. Obviously, we're not going to be able to help her too much with her weight. In fact, it's not indicated to put her on pharmacotherapy for weight management. She's not obese, but a fine needle aspiration is in order. And the cytology results, lo and behold, return as atypia of undetermined significance, Bethesda category 3. So I think we have another poll which we can launch as I read this. So the question is, what should be the next step? Would you send her for diagnostic thyroid surgery, continue to follow her with ultrasound? Would some repeat an FNA? Maybe if you don't have molecular testing, that's what you do. Or would you do one of the 3 molecular tests? Now, I don't like to bias the audience too much, but I'll just comment on something here. You know, many people have written that, and even the guidelines might make you think that if you have a suspicious sonography, that maybe going straight to surgery could be reasonable, and maybe we should be using molecular tests more selectively. That question is the focus of the research that we've done here. So it'll be at the end of the talk, and I'll tell you what the answer from our perspective is for that. So maybe we can wrap up the poll soon and share the results.
Let's give about 10 more seconds.
Okay, sure.
Because people are still voting, so we'll give just a few more seconds because I see votes are still coming in. I feel like I'm on election day here. And it's too early to call.
Yeah, I wonder if we have technology to break down the answers by geographic location. That would be
might be able to.
Yeah, we could have blue states and red states.
Right, yes.
Surgery versus molecular testing.
Okay, I think we'll end it now, even though we are still getting responses, but we probably have a statistical sampling now, so we'll end the poll.
Yeah. Okay, so I can see it. I assume everyone else sees it. And it's, you know, pretty much a draw here between repeating an FNA, which I suspect is coming from a group that might not have access to molecular testing. I don't know. And for those who do have access or who chose to do so, the Thyrosiq version 3 genomic classifier was selected. And despite my trying to sway the audience, thyroid lobectomy was not a popular answer here. Great, wonderful information. And that was the last poll. So you can all just relax and sit back. So I think we're all familiar with the Bethesda classification. And, you know, this patient had a Bethesda category 3 cytology results. We're all familiar in this audience with what that means. This shows you information from that initial 2008 NIH Bethesda consensus about the frequency with which each category might be reported and the rate of malignancies per each category, as well as back then, prior to the widespread availability of molecular testing in North America, about what other options were available. So what guidance do we actually have from the current guidelines? Remember, the ATA guidelines were published in 2015. Molecular testing was fairly new, so it wasn't featured quite as much. I'm very excited and curious to see what will come out probably in the next year or so, as the guidelines committee is working on this probably as we speak. And in the former guidelines, they discussed the role of repeat FNA, which some of you chose to do, 33%, I believe. And this is actually quite reasonable because at least half the time it will reclassify the nodule as a Bethesda category 2 benign nodule. You could send for a second opinion cytology review if you're not a high volume center. You can use sonographic characteristics to determine risk of malignancy. So there was this comment taken straight from the guidelines about the risk of malignancy in this sort of nodule, which I'll comment more on. But remember that the guidelines were written before ATA sonographic risk or TIRADS was widely used. So there's no information regarding on that. It will be in the newer guidelines, I'm sure. And then molecular testing. So here's the actual wording from recommendation 15, which, as often is the case with many guidelines, especially some parts of the ATA guidelines, it leaves a lot of room for clinical judgment. It states that after consideration of worrisome clinical and sonographic features, investigations including repeat FNA or molecular testing may be used to supplement our judgment in lieu of proceeding directly with a strategy of either surveillance or diagnostic surgery. Weak recommendation with a moderate quality of evidence. So I'll just mention a couple comments, a couple words of caution as someone who's been working in this field with the indeterminate cytology nodules, both regarding the ultrasound and the molecular profiles of these nodules. So all that we know about the sonographic risk stratification of nodules isn't directly applicable to indeterminate cytology nodules. So if you were to say that, we know that ATA high suspicion nodules on sonography, that more than 70% of these end up being malignant, as a blanket statement, that's true for all nodules. But remember, most of those on FNA are going to be Bethesda 6. But once you have the Bethesda 3 or the indeterminate cytology, actually the predictive value of ultrasound decreases a lot. Similarly, I enjoyed a lot, I'm sure you all did, the amazing talk by Dr. Nikiforov that opened our morning session today. And he discussed the prevalence of the various mutations in thyroid cancer. That also does not apply to indeterminate cytology directly. For instance, he showed that 34% of all papillary thyroid cancers in the Cancer Genome Atlas had BRAF mutations. But remember that when we're talking today about molecular testing, that we're looking at indeterminate cytology nodules. And in that group of nodules, actually, since most BRAF mutated nodules probably will end up being Bethesda 6 malignant on cytology, when you look at the Bethesda 3 or Bethesda 4 group, they're a smaller percentage, and RAS mutated nodules more likely are the largest group in most series. So just a couple words of caution that I've seen individuals applying information about all thyroid nodules to the indeterminate cytology group, which has its own unique characteristics regarding ultrasound or molecular profiles. But let's get to the meat of the talk about molecular testing. So the concept here is that if we had an indeterminate FNA and we applied a molecular test to better risk stratify the nodule, the ideal test would have a high negative predictive value and a high positive predictive value. And ideally, this negative predictive value would be similar to that of benign cytology, where there's only a 3% false positive rate. I mean, a 3% false negative rate, excuse me. And a high positive predictive value, where the ideal test would have a positive predictive value similar to that of a Bethesda 6 cytology, so a malignancy rate of greater than 90%, so that we could clearly triage the patient to thyroid surgery versus clinical or an ultrasound follow-up. Now, there are many factors to consider when looking at all these studies about molecular tests. Some of them I think are well known, and some of them are a little bit more complicated. So the well-known ones include the number of studies to support each test that we'll talk about today, the prevalence of malignancy in the studies, as well as the prevalence of malignancy at your own center, which is very important to know. Remember that test characteristics such as sensitivity and specificity are inherent and insaliable, unchangeable characteristics of a test, but the positive and negative predictive values will vary depending on the prevalence of disease in the population tested. Some studies are prospective, which is always stronger than retrospective studies and less biased. There are single versus multi-center studies, blinded versus unblinded, independent versus industry-sponsored studies. So please, each time you look at a study regarding molecular testing, take into account all of these. And then also whether they include all categories of indeterminate cytology or only one or two of these categories. Now, these remaining discussions are really more things that I've added. I didn't see in other talks that these were added to the discussion about the factors to consider. But really a huge point that I'd like to make today is that the tests have evolved to a point where this concept of a blanket calculation, especially of positive predictive value, really can't be made. So if you think back to the first widely used test when Affymetrix came out in 2012, and that well-known New England Journal of Medicine paper, it was a true binary test. So it came out as benign or suspicious. So if you have a binary test that gives you two categories, you can calculate negative and positive predictive values and sensitivity and specificity. But the tests have evolved to a point where, yes, there is a negative test and a negative predictive value can be calculated. But the positive test, actually, as Dr. Gulick would like to talk about, would be a positive prognostic value. You can have different types of positive results. The tests are much more granular, giving you so much more clinical information. So a general positive predictive value can't be calculated. It depends on the mutation. As you know, if you have a BRAF V600E mutation, the positive predictive value is 99%. Whereas if you have a RAS mutation, it's much lower, and so on and so forth. In fact, in our series of Bethesda 3s, we found a handful of TSH mutations, TSH receptor mutations. Those of you who are familiar with this may know that, well, is that a positive test? it's a positive test, but it should be included probably as a negative test because TSH receptor mutations are much more commonly associated with benign nodules. In fact, they're commonly seen in overfunctioning or hot or warm nodules. So this becomes an issue, and not all studies may have made this separation about what they're considering positive in their positive predictive value calculations. Another big one for me, which is a little controversial, is how we include these quote unquote benign pre-malignant neoplasms. Are we going to consider them a positive result? Again, Dr. Nikiforov outlined this very nicely, that follicular adenomas, Hürthle cell adenomas, and NIFT-Ps perhaps should be considered pre-malignant. They're on their way to perhaps on the pathway of evolution into their more invasive counterparts, the follicular carcinoma, Hürthle cell carcinoma, and the invasive follicular variant of papillary thyroid carcinoma. So, I feel that it's good to detect these and it's good to remove them. But others actually who are, quite prominent in this field don't feel this way. The duration of follow-up of patients, especially those who had negative molecular testing, is quite variable among studies. And the percent that have actually undergone the gold standard diagnostic test, which is histopathological surgical confirmation, is quite different. And this becomes very important, especially again in calculating the negative predictive values. And many studies, including ours, report findings using older versions of testing platforms. And the testing platforms continue to come out with newer versions. In fact, I've run into trouble getting some reviewers to accept some of the papers we've written because they say this is an older version of the platform that you've investigated. So here's the 3 tests that are available, starting sort of a little bit with chronological order with the Affymetrix test. And what Affymetrix tests is messenger RNA, mRNA, whereas the Thyroid plus Thyromere test involves an assessment of genetic alterations involving DNA, messenger RNA, and it's the only test that currently also assesses microRNA, which, as we discussed earlier this morning, are regulators of gene expression. We'll talk more about why that may be valuable later when we get to that section. And then the Thyrosiq test, which started off as purely a DNA test, but in recent years has also added an expression classifier to the platform. So here's a comparison of all 3, just in terms of what's really done. The genomic sequencing classifier, which is the Affymetrix GSC, which has replaced several years ago the GEC, the Affymetrix gene expression classifier, uses RNA sequencing to assess gene expression with an analysis for upstream mutations of a few very important strong driver mutations, such as the BRAF V600E and 2 fusions, the RET BTC, and also has the expression atlas, as you can see, of 761 variants and 346 genes and 130 fusions. This Affymetrix test is recommended to use 2 dedicated passes, for those of you who are doing it in the office, but some places get by, they tell me, with 1 pass. And it's reported binary as benign or suspicious. The multi-gene genomic classifier, also known as Thyrosiq GC version 3, uses next generation sequencing of DNA and now also of RNA, looking at over 12,000 variants in 112 genes, over 120 gene fusions, and now in more recent years added to this is the gene expression that I mentioned earlier. And then the copy number alterations, which were discussed this morning, are particularly valuable in identifying Hürthle cell tumors. And then lastly, we have the multi-platform test, which is actually 2 tests, the ThyGenNext plus Thyromere, which uses next generation sequencing of DNA and RNA, 10 genes, 38 fusions, and 10 microRNAs. You can see at the bottom that the samples that are acceptable for submission for the Thyrosiq and the ThyGenNext Thyromere are fairly similar. Most of us send 1 dedicated pass, or if needed, cell blocks or slides can be sent. The Thyrosiq is often reported as negative or positive. And the multi-platform test is fairly unique in that you can have a negative, positive, but then almost a third of cases will return as a moderate risk group. I'll show you what that's all about a little bit later. So here's a comparison about how robust the data sets are currently in the current literature. You can see the various parameters that we value that we want to compare. On the left, the analytical validity, which tells you about test performance, accuracy, and precision. the clinical validity, which is the presence of prospective multi-center studies with blinded central histopath review, and if there are independent post-validation studies. Being around for quite some time now, you can see that the GSC and the Thyrosiq GC have more robust study and literature supporting them than Thigenex Thyromere has at this point in time. So let's talk about the Affymetrix GSC a little bit. Now, what is the protocol when you send your samples? What's actually done? Initially, the sample is run through some initial classifiers to identify rare neoplasms and the strong driver mutations that have a very high risk of malignancy. So identifies parathyroid, medullary thyroid cancer, and BRAF mutated RET-PTC fusions. Then a follicular content index is run, which identifies samples with sufficient follicular content. If not, it's reported as insufficient sample, and oftentimes the test needs to be repeated. After that is really the machine learning algorithm. I think it's proprietary, so we actually don't know, that was developed and redeveloped over the years and refined with the gene expression, mRNA expression analysis. And this was initially done to try to find a signature, an expression signature of benign nodules. So it leverages multiple algorithms to derive the final benign or suspicious results. And then I think in recent years, where all the tests have improved, is really telling us more about what to do with these Hürthle cell neoplasms. In the early years, I was very familiar with several papers that had come out about the old Affymetrix GSC, where it wasn't very accurate at telling you whether a Hürthle cell neoplasm was benign or malignant. And you can see that the additional analyses done there to improve the performance in that regard. So this is a slide showing you several parameters. I'll walk you through it and tell you what it talks about. I think it is a little bit selected to show studies that are more in favor of strong test performance. So I will, my job is to try to provide as much of a fair and balanced view of all the tests, and I'll provide you with additional information as we go on. So you can see all the references of the select studies that were used for this slide below. And on the left here, this panel that you can see on the left, is that you're looking at the benign call rate. And initially I think with the GEC it was lower, and now it's probably closer to 60%, maybe a little bit lower. On this slide, it's represented as a little bit higher than 60%. And then the sensitivity and negative predictive values, again, these are select studies with very good results. There's also several studies that show slightly lower negative predictive values. So it might be closer to 94, 95%. In our own series, which was published in Thyroid, and I'll show you the data at the very end of my talk today, we actually found that even if we were to include all negative Affymetrix, now a big grain of salt here is that we were looking at the old GEC, not the GSC, but for what it's worth, even those tests negatives that were lost to follow-up, that the negative predictive value was close to 90% with the old GEC. No doubt it's improved with the GSC, and that's what I'm talking about today. You can see the positive predictive value. Many studies have now put it better than the old GEC, which was actually quite low, close to 40%, and getting closer to 60% now with the GSC. And then what many of us care about is the clinical utility, which means in real life practice, how many surgeries are we able to avoid? And it looks like, perhaps a third to 40% or so of patients who've had this test end up going to surgery. So maybe 60% or more, may be able to avoid surgery by having this test done. Where does the expression atlas come into all of this? And the expression atlas, which has been developed most recently as part of this diagnostic platform, may help a lot with the suspicious results. So you can see here that the Affymetrix expression atlas result could help us further refine the test performance for the risk of malignancy, which is about 50% with the Affymetrix going into it for all the suspicious results. But there may be a subgroup here around 40% that this can identify alterations that would increase that risk of malignancy and provide more granular data that would inform our not just our diagnosis, but our management for these patients. And I won't show you reports of all the different tests. You may all be familiar with the Thyrosiq reports, but I included one here to show you that all companies now provide you with a report that has a lot of useful clinical information. You can see clinical relevance, the results interpretation, references, algorithms. This has really improved since these all first started being reported so many years ago. And the point that I made earlier, again, which is a little bit controversial, and I'd love to hear what others think about this, but it seems like Dr. Nikiforov and I agree on this, is that the molecular tests are very good at identifying neoplasms. So even if it's reported as a benign neoplasm, I feel that that's good that it's been identified, and that if you sit on those, that they may actually eventually transform into malignant neoplasms. And a good example of this is what happens with the Affymetrix suspicious nodules. So you can see here a series of Affymetrix suspicious nodules, and most of them are actually neoplasms. So only a very small group here, 11%, were adenomatoid nodule. That's an old word for saying hyperplastic nodule. So those are polyclonal lesions. They're not neoplasms. You can see most of them, even though they were benign, and we're calling these false positives, were follicular adenomas and Hürthle cell adenomas. So it really depends on how we look at at the progression of cancer. And I'm very familiar with this from other endocrine tumors as well. For instance, those of you who see patients with neuroendocrine tumors also understand that the distinction of what's benign and what's malignant sometimes is just a matter of time. If you sit on what we think is a benign neuroendocrine tumor, it'll start to behave malignant. So you have these borderline precursor lesions. Let's move on and talk a little bit about the Thyrosiq test, which I think many of us are most familiar with. The history here is one of an evolution that you can see that's very rapid over the years with increasing test sensitivity. Usually when you improve sensitivity, you tend to lose specificity, but that actually hasn't happened much. It's been able to keep up, which is a tremendous accomplishment, I think. You can see the test procedure here, and in the interest of time, I won't go through it too long. Dr. Nikiforov and others have delineated this. It's very similar, that there's an assessment for adequacy, FNA cellular composition determination to tell you if you're dealing with medullary carcinoma or parathyroid tissue, and then the next generation sequencing analysis for 4 classes of genetic alterations, which could be mutations, gene fusions, copy number alterations, or gene expression alterations. And ultimately, you get a result as negative or positive. And the positive results provide very detailed genomic findings. And I think that's why many of us who use Thyrosiq more often than the other tests have been very happy with that, enhanced detailed genomic findings to inform our management. The Thyrosiq, as you saw on an earlier slide, has been validated in many studies. And this is just one example of a large prospective double-blind study, the type of study that we're interested in. And the sensitivity and specificity were relatively high, with a high negative predictive value of 97%. And again, I don't believe in a blanket positive predictive value anymore for these tests, but it was reported at a 66%, which is fairly average for studies of Thyrosiq. But again, there are some studies that show lower positive predictive value depending on how they group the mutations. And a reasonable 61% avoidable surgeries or benign colorate was reported. Here's just a little depiction for everybody of how the test performed in that study regarding the different histologies of the tumors, especially the malignant tumors, and its sensitivity for detecting each category. And the Thyrosiq test has been validated in several independent studies. And you can see there's a big difference in positive predictive value, as one might expect in some of these studies. And I have seen a couple of studies that have shown quite a bit lower positive predictive value. But the majority show you numbers in this range. So the way the Thyrosiq tests come out, again, are not binary. You can have a negative test, which is quite common. But then when you have positive genomic alterations, there's several different categories. And these are very helpful. You can see that there's a currently negative low risk, which gives you a risk of malignancy less than 10%. This would be probably that TSH receptor mutation and others that I talked to you about. And the positive high risk mutations. I think for all of us, the challenge is what to do with these more intermediate risk mutations, especially these RAS-like tumors. And the Hürthle cell tumors, we've come a long way, but still also, I think after the RAS is another area where the tests continue to be refined and improved. And we've all probably wondered what would happen if we did a study where we had patients undergo both tests and followed prospectively, and most of them get submitted for surgery. To the best of my knowledge, there's no such large study, but there is this wonderful study out of UCLA where the patients were randomized by month to one of the 2 tests, the Affymetrix and the Thyrosiq. And their findings actually were that there was really no statistical difference in their series in the test performances. There were a couple of small differences that were shown here, that the samples that were inadequate for testing were a little bit lower with the Thyrosiq, and perhaps the benign call rate was slightly better too, with p-values that met statistical significance. Again, a little comparison here for all of you. And I think what we're very interested in is, our ability to avoid surgery. So you can see the benign call rate from clinical utility studies, fairly similar, around 60%. What about the ThyGenext Thyromere? So this is a two-step test, or actually two different tests. The first step is the ThyGenext mutation and gene fusion panel. And you can see all of the genes that are tested, the most common familiar genes that we're familiar with, including TERT. There was a lot of talk today about the TERT promoter. So both Thyrosiq and ThyGenext can test for the TERT promoter mutations. The Affymetrix can't, because it's a promoter mutation, so it's not expressed. You can't see that signal in the RNA, or at least the messenger RNA analysis. And then the Thyromere is the unique aspect of this, which is the expression of 10 mRNA genes shown here and listed in the slide. And the idea here, which I don't know that it's been prospectively proven, is that the mRNA analysis may be valuable in predicting behavior of nodules with weak driver mutations, such as RAS mutations, and also in nodules, perhaps some of the nodules that are negative for mutation testing. So this is the three-tiered reporting system that you can see here, a negative, moderate, or positive test reporting system taken off of the website. And this is the one major study that most people look at. There's another one, I think, with Dr. Stewart before this, showing you how the test was reported. And you can have a negative, positive, or this moderate risk. And you can see if you have a negative result, it pans out quite well, that only 4 out of 81 were malignant. And the positive result is also fairly decent, with 35 malignant out of a total of 47. But the issue here is the moderate risk group, which is about 28% of all of the patients that were assessed. The risk of malignancy was exactly 30%. So that's in the moderate risk group, the risk of malignancy is the same as if you'd never done the test. Usually the prevalence of malignancy was 30% in the entire sample anyway. The benign call rate perhaps was a little bit lower at 46%. And lastly, and this is a big point, since this is a non-binary test, the interpretation of the moderate risk category in calculating the positive and negative predictive values was done in such a way that these calculations really aren't true. I mean, this isn't really the positive predictive value of the test, because they were lumped, the moderate risk group categories were lumped together in such a way during the calculations in favor of making it look a little bit higher. So it may be closer to 50% based on a letter to the editor that was sent after this was published. And then my last slide is really the idea about that ultrasound. And I'll summarize our studies in just one slide for you. And the idea here is that our current strategy is to indiscriminately, after indeterminate cytology, do a molecular test. Now, it's thought that there's about 75,000 molecular tests done in the United States annually. And let's say if these cost at least $1,000, I mean, I know they cost more, but I don't know what insurances pay, that would be $75 million spent, I don't know. So can we triage nodules based on sonographic risk and only send some of them? Maybe if perhaps high suspicion sonography or low suspicion sonography gives you such good information that you don't need to do molecular tests. And then also our other question has been, do the molecular tests perform the same across all sonographic risk categories? So I'll just summarize what our studies, and then also a study with Dr. Nikiforov and a multi-center group. Our University of Miami studies here, published with one of our residents, Marilyn Arosa Mena, and myself in Thyroid in 2020, involved older versions of the test, the GEC and Thyrosiq V2. And we looked at both ATA sonographic risk and TIRADS. And the bottom line was that sonographic risk alone was not an adequate predictor of malignancy. There was a modest correlation of the sonographic risk category with the molecular test results. The negative predictive value of both the molecular tests we looked at was really not altered by the sonographic risk category. And while 75% of high sonographic risk nodules were indeed Thyrosiq positive, the negative predictive value was actually 100% in that group. So that 25% of the high sonographic risk nodules that were Thyrosiq negative, they were all found to be benign on surgery. That was our series, but it's a small single center series, so it needs to be confirmed in others. The positive predictive Affymetrix of the old Affymetrix GEC was slightly higher in the higher sonographic risk categories. while the PPV of Thyrosiq was fairly similar across the sonographic risk categories. And then after ours, you can see that this large multi-center study that's more recently published in Thyroid found that neither the ATA nor the TIRAD sonographic risk scoring systems further informed the risk of cancer or NIFP beyond that predicted by the Thyrosiq version 3. So with that, I'll conclude and remind you all that molecular tests are currently valuable tools in the management of thyroid nodules with indeterminate cytology. Testing algorithms have evolved and improved rapidly in the last few years to improve specificity and PPV while maintaining a high sensitivity in NPV. I actually think the most commonly used two tests have become more and more similar to each other as the years have gone by. And currently there's more robust studies to support the clinical validity and utility of Affymetrix and Thyrosiq when compared to the Thygenext with Thyromere. There's considerable heterogeneity in the methodology and results reporting of various studies of molecular tests. Molecular test performance is not meaningfully altered by sonographic risk, and long-term follow-up studies of outcomes in patients undergoing these molecular tests are needed, especially for non-operated cases who had negative test results. And I put here a little picture of a thyroid nodule that one of my colleagues showed us in her clinic. It looks like a heart. So this isn't fake, it's real. So I like to share this in all my talks. Thank you all for your attention, and I apologize for going a few minutes over.